Now, on essential hypertension or primary hypertension, uh, which is the commonest, we have to discuss right now on what would be expected of us and what is it all about. The normal blood pressure is the value less than 120 millimeters of mercury systolic over 80 millimeters of mercury diastolic. And that number is not that it's going to be extremely low below 90 over 60. No, that is hypotension. When there's ambulatory blood pressure monitoring, any value greater than 130 millimeters of mercury systolic over 80 millimeters of mercury is not good. The diagnosis is made when the blood pressure is greater than 140 millimeters of mercury over 90 millimeters of mercury. In diabetic patients, we tend to look for a lower BP compared to the general populace because we need to keep an eye on them. So the BP recommendation here to make the diagnosis of hypertension in a patient with comorbid diabetes mellitus is any value greater than 130 over 80. If my grandfather is 80 years or greater, I won't bother about 140 over 90. I'll be looking for something like 150 over 90 millimeters of mercury. So if my grandfather that's 80 years plus is having BP of 145 over 85, I'm not going to call it hypertension. When the home blood pressure is greater than 135 over 85, then hypertension could be diagnosed. That's what we call isolated systolic hypertension, and that is when systolic is greater than 140 and diastolic is less than 90. In Europe, that is the diagnosis of isolated systolic hypertension. But in North America, by American Heart Association, is when systolic is greater than 130 and diastolic is less than 80. So when systolic is greater than 140 and diastolic is less than 90 in Europe, that is isolated systolic hypertension. But in North America, with American Heart Association, it is greater than 130 systolic and less than 80 diastolic. What are the signs of end organ damage in an individual that has been diagnosed with hypertension? Renal damage will lead to increased creatinine. The central nervous system will yield altered sensorium. And of course, when you do your ophthalmoscopy, you see papillary edema or bulging disc. What are the predisposing factors? If you are listening to my presentation on myocardial infarction, I have highlighted the modifiable and non-modifiable risk factors. The same thing is applicable here. In case of modifiable risk factors, a lot of them from diabetes mellitus, if well treated, should not be leading to complications like hypertension. Smoking, you have the choice to stop it. If you can, that would be great. High lipid, take your statins, work with your doctors, get it under control. Watch your diet, do exercise, and on the likes. Inactivity or sedentary lifestyle is a problem. Get off the couch, walk around, walk your dog, play any sport you like, make yourself active, and you'll be helping the diagnosis to get down. Increase salt intake. Please decrease it. 1.5 to 2 grams per day is enough. Stress. If you can, get out of it. Alcohol. Nobody is forcing you to take it, so control yourself, please, for the sake of your heart, your BP, and of course, your life. Drugs. I'm here again. No cocaine, no fentanyl, no amphetamine, no phencyclidine, no methadone. No, just don't do it so you can enjoy yourself. Poor diet, all junks. You know how to eat healthy, balanced diet. There are a lot of pamphlets, go online. I may even be making some presentation on good diet very soon. Obesity, the bigger I am, the bigger my BMI, the closer I may likely be to the grave. Predisposing factors, non-modifiable this time around. Family history, particularly with its in first degree relatives, your dad, your mom, watch out. Age, if you're having hypertension at younger age, I have presented a kind of series of PowerPoints on secondary causes of hypertension in the young. Please check it out. It's just the one before this very one. Race. Yeah, I'm respectful to everyone, but the fact remains the fact that African Americans, blacks, have essential hypertension more than the rest. Gender, male, and postmenopausal women will suffer more than the rest. Well, before leaving this very section, you just need to know there's nothing you can do about this. But if you belong to all these non-modifiable groups, then watch out the modifiable factors. So if you are able to balance that up, then leave yourself to what fate has for you. Test. You do fasting blood sugar to rule out diabetes mellitus if you have never been diagnosed with it before. You want to know what is happening to the kidney, so you do renal function test. You do electrolytes, complete blood count, thyroid stimulating hormone to know what is happening to the thyroid gland, and of course, vinyl mandelic acid in case we want to rule out pheochromocytoma. How you present, the age, the race, the gender will determine what and what we'll be asking for. Radiological investigations are necessary. EKG from the one, we want to know what is happening to your heart, by the electrical, imaging on the strips. We can use Doppler ultrasound to rule out bray along the carotid, just to be sure, and CT angiography, magnetic resonance imaging angiography, echo to rule out left ventricular hypertrophy, particularly if there's coarctation of aorta. If you can listen to my presentation on hypertension in the young, and then you listen to this one, then you'll be able to match the two and you'll be on the right path. When we start treating hypertensive patients, essential hypertension, elderly man or woman, we have targets. And the target is BP less than 140 over 90 millimeters of mercury in the general populace, but we go a bit lower if the individual is having diabetes mellitus as well. By that time, we look for something lower as 130/80 millimeters of mercury in diabetes mellitus patients. The non-pharmacological intervention will be to counsel you to decrease your weight, exercise more, watch what you eat by letting you know that there's a diet aimed at stopping hypertension, and dietitian could help out, and of course online and some pamphlet will help. Decrease your salt intake, please, to about 1.5 to 2 grams per day. Kindly stop smoking, and of course it will be helpful if you can decrease the alcohol intake and manage your stress appropriately. Pharmacological treatment. As a matter of fact, I'm going to have a separate presentation that will take minutes on medications for hypertensive patients. But just briefly here, let me summarize that the first line is thiazide, hydrochlorothiazide or chlorothalidone. Then we use ACE inhibitors, that is angiotensin converting enzyme inhibitors, the host of them. But if there's allergy and that presents in form of angioedema, then we use angiotensin receptor blockers. Don't worry, there's another video coming where I'm going to talk in details about all this. We use calcium channel blocker, particularly for blood pressure. We use the hydropyridine, nifedipine, amlodipine, felodipine, and the rest of them. But we use non-dihydropyridines, still calcium channel blocker. Example is diazepam and verapamil if there's associated arrhythmia. We use beta blockers that are beta-1 selective like metoprolol and atenolol, and beta-1, beta-2 non-selective like propranolol. And most of the time we use combination of meds. Vasodilators like nitroprusside, nitroglycerin, isosorbate mononitrate that we mostly use in heart failure, isosorbate dinitrate also in heart failure, statins, and aspirin are all useful. Don't worry, there's a separate audio for medications in hypertensive patients. Complications. It's possible we're dealing with malignant hypertension, you're doing everything, you're not getting out. There's possibility of hypertensive emergency, the BP is up, there are signs of end organ damage. Or hypertensive urgency, the BP is high, but no signs of end organ damage yet. Can lead to heart failure, can lead to hypertrophy of the left ventricle, can lead to ischemia, can lead to myocardial infarction, stroke. As a matter of fact, most people with essential hypertension will be diagnosed for the first time in some other parts of the world with stroke, hemorrhagic stroke. Could also lead to ischemic stroke as well. And of course, death is possible because most of the time hypertension is asymptomatic. In conclusion, we are not done yet. The next video will be on anti-hypertensives. I'm truly wishing all affected people well. Thank you for watching my videos. Kindly subscribe so that I can get these videos on a timely basis. Thank you.